We are live now.
Live. Okay. So, can you hear me, Manjula?
Yes, Dutta.
Okay. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. It gives me immense pleasure to welcome you all for the 6th masterclass of the online postgraduate teaching program, which we have named Kaksha. So, Kaksha for all the new students here is a novel PG teaching program envisioned by ROS, in which we will cover all the major topics over a period of next 2 years of the current curriculum of ophthalmology residency program. We'll be bringing the best of the national and state faculty experts to share their knowledge and interact with you. The residents are also encouraged to put forward their doubts in the chat box in a fearless manner, and we will address to every question with the speaker. Coming to this class, we have today with us my very dear friend, Dr. Parthopratim Majumder from Shankar Netralaya, Chennai, to enlighten us about one of the most important topics and the most frequently seen conditions in the OPD, uveitis. Basics and workup should be known by every ophthalmologist. I welcome the ROS executive, the president, sir, Khilnani, sir, Dr. Sanjeev Desai, our president-elect, and the dynamic secretary, Dr. Ghulam Ali, for today's class. Today, we have 3 postgraduate students in the hot seat, Ayushi, Sahil, and Kavita. Ayushi, I guess, is from Ajmer, Sahil and Kavita from Jaipur Medical College, and they're all final year postgraduates from different colleges. And Dr. Patho is encouraged to interact with these students and not be very strict with them. In the end, there will be a grand quiz with exciting prizes. So keep a strong vigil and listen carefully to Dr. Partho. Dr. Parthopratim Dutta Majumder works as a senior consultant in Shankar Netralaya, Chennai. He has received several awards: Dr. T.L.K. Rao Endowment Award, Dr. Nataraj Pillai Award, Dr. K.R. Dutta Award. He has published more than 125 articles in indexed journals. He is involved with almost all journals of ophthalmology as a reviewer. He has authored 65 plus chapters in various ophthalmology books and edited 4 books: Recent Advances on Uveitis, Retinal and Choroidal Imaging in Systemic Diseases, Modern System of Ophthalmology, Uvea, and Essentials in Ophthalmology for the Postgraduates. 2 CME series or monographs authored by him on PCR in ophthalmology and scleral inflammation, published by AIOS. He is elected member of the International Uveitis Society Study Group and currently serving as a treasurer of the Uveitis Society of India. He is the founder cum chief editor of popular ophthalmology portal. You must have all visited eophtha.com. It is hugely popular amongst postgraduates. Partho, your class is almost full now. We have more than 60 students. We can start and they'll keep on growing as the class progresses. Over to Partho for his deliberation. You can share your screen.
So I hope I'm visible and you all can hear me.
Yeah, you are audible and your screen is visible, Partho.
Yeah, thank you. Thanks for the kind introduction, Vishal. So good evening all. At the outset, I would like to thank my friend Dr. Vishal Agrawal for initiating this concept of Kaksha and having me here. I would also like to thank my senior colleagues and friends, Dr. Kamlesh Khilnani sir, the Ghulam Ali Kamdar, Dr. Sachin Desai, and Dr. Harshul Dutta. So, today, I'll be talking mainly about the basics of uveitis and how to do workup in a case of uveitis. So this talk is actually intended for the postgraduates, and I have tried to balance it theoretical and practical inputs from the clinic. So I'll be happy to know your feedback. If you have any suggestion or any query which you may not get a chance in during this conversation or this class, you may actually write to me. My email ID is here. So now, how we approach a case of uveitis. The moment you see a patient with uveitis in your clinic or in your practical exam, what you do, you go in a methodical way. You take history, you try to classify the uveitis, and you examine the anterior segment, then you examine the posterior segment, and try to examine various systems. And then what you do, you try to achieve a diagnosis. But the most interesting point in clinics and in exam halls, it is the ability of having a proper differential diagnosis that makes you different from others. Now, this differential diagnosis is all about considering all the possibilities and narrowing them down to probabilities. Clear? So we'll highlight in developing the skill of having a differential diagnosis. And differential diagnosis means considering the possibilities and narrowing these possibilities into probabilities. So this is we can achieve in a step-by-step manner. Now, the most important step is the history taking. As you know, the William Osler actually said that listen to your patient, he is telling you the diagnosis. Now, the problem is what we do, we just directly take the history and then straight away go to examination of the patient. Now, few things you have to understand that you have to take the history in a two way. First, you have to take the history of symptoms and you have to evaluate the descriptors of uveitis. We'll discuss what do we mean by the descriptors of uveitis. Then we should perform a comprehensive eye examination. That means you should do a thorough slit lamp and fundus examination. Then again, you should take a proper detailed history to achieve or identify the clinical phenotype. Clear? So don't take history at the beginning and then start examining. At the beginning, just take the history of symptoms. Try to understand that what are the different descriptors of the uveitis fitting into, and then go into the clinical examination and then try to make a differential diagnosis and then again start history taking. So now few things you have to remember, that the best history question does not give you an answer. It gives you two more good questions to ask. Always remember that. Now, one thing you have to remember, that you have to be very careful about a history of pain when you are eliciting that history of pain, the drug compliance, and the high risk behavior. The patients may lie, so you have to cross check, and blindfoldedly you should not believe your patients. So remember, many a time our patient, they cannot differentiate between what is irritation and what is ocular pain. So you have to cross question them and you have to make sure that what is the exact symptom the patient is having. Similarly, the joint pain, every patient will come to you, will complain of some kind of joint pain. Now you have to delineate the history, you have to ask relevant questions so that you can differentiate the inflammatory cause of joint pain from the other joint pain like degenerative condition. Now osteoarthritis patient, they will also have a joint pain, but these are not the inflammatory joint pain. So you have to actually ask question and you have to differentiate them. Next is, always you remember, while taking a history, just because a patient does not have a history of a particular condition does not mean that it cannot happen to the patient. You have to remember every disease has a first occurrence. For example, the TB. I often see my resident, they will be taking, is there any history of contact with tuberculosis? It's not there, doesn't mean that the patient cannot have ocular TB or any pulmonary involvement. So it can be every disease can have a first occurrence. Now, before we move into the clinical examination, you have to understand that how we classify the uveitis. Now, there are two classification, mainly we used for historical purpose. Nowadays also we are using it. These are called Wood's classification and Duke-Elders classification. Can anyone, Sahil or Ayushi, tell me what is Wood's classification?
So according to Wood's classification, we classify it as granulomatous and non-granulomatous uveitis.
Very good, very good. Now, anyone, Kavita, can you tell me what is Duke-Elders classification of uveitis? Anyone? Ayushi, Sahil, or anyone? These are
In
all.
Duke elders,
Yeah, tell me.
sorry. In Duke elders, we classify it as traumatic, infectious, immune related.
Very good, very good. So these are Duke Elder. Long back, they actually devised the etiological classification. And as you pointed out rightly, the Woods classification is also known as clinico-pathological classification. That means you perform a slit lamp examination or the comprehensive eye examination, and you try to pick up some pathological feature which is visible in under slit lamp or fundus examination. So that's why it is called clinico-pathological classification. So how we divide it? We divide it into granulomatous and non-granulomatous uveitis. Now the granulomatous uveitis, the onset is insidious, and in non-granulomatous, the onset is well defined, and the course is acute in non-granulomatous, and there will be a lot of congestion, severe pain, and usually associated with fine capes, and iris nodules are usually absent. Now, can any one of you give example of a non-granulomatous uveitis?
HLA-B27 associated
Very good.
conditions.
So you have to yes. So you have to understand the onset here. The patient will come here, patient with the granulomatous uveitis. You will ask when the symptoms started. The patient won't be able to pick up. They will tell it may be 3 months back or 1 year back. So they will be not sure about the exact onset of the disease. Whereas the non-granulomatous uveitis patient will give you a history like that. 13th March, I went to that place, and from then my eye pain started. So it was so acute, or hyperacute, that patient can't actually identify and pinpoint the date. So that's how a non-granulomatous is defined. So correctly you say the example of non-granulomatous uveitis is HLA-B27. And granulomatous uveitis, the examples are tuberculosis or sarcoid. Now, the problem with the Woods classification or the clinico-pathological classification is it's not very reliable, can change the clinical phenotype. The classical example is sarcoid. It can often present with non-granulomatous, and after a certain period of time can become granulomatous, or it can present with granulomatous or can become non-granulomatous also. So there may be frequent overlapping of the various clinical phenotypes. So these are not very reliable, and that's why not universally accepted. Now, when we talk about universally accepted classification, we should know that why we need to have a universally accepted or recognized classification. Any one of you? Ayushi, why we need an universally accepted or recognized classification?
So that the nomenclature is standardized so that it can be used at different places.
Yeah, different cases. For example, sitting at Jaipur, if you are examining a patient and if you are writing the finding, I can actually correlate it from Chennai because there is a universal agreement on that. So when you are mentioning that +3 cells anterior uveitis, I can make out that what is the intensity of the uveitis and where it is located. So that's why we need a universally accepted classification. And it all started actually by IUSG, International Uveitis Study Group, which devised the first uveitis classification in 1987, and then actually came the Sun classification. Can anyone, Sahil or Kavita, can tell me the full form of this Sun classification?
Sir, it's standardization of uveitis nomenclature.
Yes, very good. So standardization nomenclature, uveitis nomenclature is the Sun classification. Now, IUSG classification, they anatomically divided the classification like anterior, intermediate uveitis and posterior uveitis. Whereas the Sun classification, they brought the concept of primary site of inflammation. They suggested that if the anterior chamber is the primary site of the inflammation, then we'll call it anterior uveitis. If the vitreous is primary site of inflammation, then we'll call it intermediate uveitis. And they also mentioned that if the vitreous is the primary site of inflammation and if there is a secondary pathology to it, for example, this vitreous inflammation is due to tuberculosis or sarcoidosis, then we'll call it intermediate uveitis. Whereas If there is no associated cause or it is idiopathic, then this intermediate uveitis should be termed as pars planitis. Now, when the primary site of the inflammation is retina and choroid, then we call it posterior uveitis. Now, when we observe inflammation in anterior chamber, vitreous, in retina and choroid, but we cannot make sure where the primary site of inflammation is, because everywhere there is inflammation, we can't pinpoint a particular site from where the inflammation originated, then we call this as panuveitis. Now here you have to understand the spillover of the inflammation in AC, and in anterior chamber there will be some spillover of inflammation in the anterior vitreous. So Sun classification has divided that whenever there is a high amount of spillover inflammation in anterior chamber, and the same kind of inflammation is there in vitreous also, but we cannot pinpoint where is the primary site of inflammation, whereas it is in anterior uveitis, anterior chamber or vitreous, then we should use the term both anterior uveitis and intermediate uveitis. Clear? Any doubt you have? Any? Sahil, Ayushi, okay?
Yes, sir.
Yes, sir.
So next, the first entity, when we examine the patient, we see that how congested the eyes are. Now, all of you know there are several causes of red eyes, and we need to differentiate it from various causes. Like we differentiate it from anterior uveitis to angle closure glaucoma, and we have to differentiate to conjunctivitis also. Now, always look carefully at the congestion. Look whether there is any chemosis is present or not, whether it is associated with any discharge. Examine the cornices very carefully, because some inflammation, for example, the brimonidine associated uveitis is characterized by severe congestion of the cornices and anterior uveitis. So carefully examine the cornices. Don't hesitate to use topical vasoconstrictor in certain cases. I will go to that. So the next important is that beware of white eye uveitis. Now there are certain conditions where the eyes are not congested, it is white, but there is intraocular inflammation. Can you people name some conditions?
The Fuchs
Juvenile
cyclitis,
rheumatoid arthritis.
sir, toxoplasma.
Yes, very good. So pars planitis, Fuchs uveitis, juvenile idiopathic arthritis, white dot syndromes, toxoplasmosis, toxocariasis, and various muscularite syndrome can actually present with white eye uveitis. So white eye does not mean that the eye is not inflamed. So now another most important point we should know that scleritis versus episcleritis. Many a time the patient will come, as you can see here, the first picture, the patient is having scleritis, and the second one, the patient is having episcleritis. Now 3 points you have to keep in mind. One is the pain. The pain in scleritis is boring in nature. It usually actually worsens at night. So the patient will give history that the pain in scleritis wakes him up at the night, whereas in episcleritis there won't be any pain. Second important point, the patient with scleritis won't allow you to touch the eye. The moment you will touch the eye, he or she will jump from the chair and won't allow you to examine the patient. Whereas in episcleritis, no such tenderness will be there. The number 3, which is most important and most valuable, is phenylephrine test. Just put a drop of phenylephrine in eyes. In patients with scleritis, the vessels won't blanch because the deeper episcleral vessels are also congested. Whereas in episcleritis, only superficial episcleral vessels are congested. So the vessels will blanch quickly in episcleritis. So now coming to the congestions, after finishing the congestions, you have to look for signs of inflammation in anterior chamber. Now this can be done by various. We have estimation of the cells player. We also check the involvement of the cornea, involvement of the iris, involvement of the angle of the anterior chamber, and cells in anterior vitreous. So all of you actually, you can go through my class in eye focus, where we have discussed the various pathological event, what happens during an inflammation. So I won't go into the details of those aspects. I am sure you all already know of how this happens. So straight away we'll go to the descriptors of uveitis. As I pointed out there, so descriptors, Sun classification has identified 3 descriptors. One is onset, the second is duration, and the course. You have to remember one thing, that 3 month is very crucial period in uveitis. In every entity, they have defined it in terms of 3 months. For example, a cataract surgery, the eye should be quiescent for at least 3 months. So in various, for example, onset, I don't have to tell you that what are the different type of onset. Already we have discussed. It is sudden and insidious. The duration is based on the 3 month. So limited means it is less than 3 months of duration. Persistent means it is more than 3 months duration. Correct? So now coming to the course, you have to understand the course is actually classified into 3 groups. One is acute, recurrent, and chronic. Now acute means episode with sudden onset and limited duration. Whereas the recurrent and chronic, so you have to understand the recurrent and chronic with an important point. One is that recurrent means the repeated episodes separated by period of inactivity without treatment for more than 3 months in duration. If you look here, this is the treatment part. Now this duration, if it is more than 3 months duration, then we call it recurrent. Clear? And if this duration is less than 3 months, but it runs a persistent course, then we call it chronic. Clear? Any doubt? Recurrent and chronic? Ayushi, Sahil, anyone?
No, sir.
No, sir.
So recurrent and chronic, we are clear now. So now we'll go to the few other descriptive. The inactive means that they have actually tried to quantify everything on the basis of cells and flare. So in that, they have actually presumed that the grade 0 cells in anterior uveitis will be labeled as inactive, whereas the remission is inactive disease for 3 months after discontinuing all the treatments for eye disease or eye inflammation. Now worsening and improvement, they have defined with a 2-step increase in the level of inflammation or increase in highest order, like from grade 3 to 4. If it is going, then we will call it worsening of uveitis. And similarly, if it is directly comes to 0, then we'll call it improve activity. So this is how they divided the various stages of the classification. Now here in cells and flare, you have to understand that they quantified actually the breakdown of blood ocular barrier with this. So now this method where you make a slit lamp beam of 1 millimeter into 1 millimeter and try to count the cells. Now it is very good for documentation purpose, but it has some intra observer bias, because for example, you may find it 0.5 cells, whereas I may count it as little higher, or it may be much less. But it is very good for monitoring the activity and research purpose. So it is widely used in documentation and research purposes. Now, second, similarly, the flare. So now coming to the flare, if you see, so physiologically, if you see, the normal aqueous also can have some turbidity, because our normal aqueous has almost 11.2 microgram of protein per 100 milliliter of aqueous. Now, this is sometimes, often it is first sign of uveitis and may persist despite the adequate control of the inflammation, and it may not be possible for us to visualize always. So that's why there is a instrument called laser flare photometry, which quantifies the anterior chamber protein by measuring the light scattering with the help of a helium neon laser. What they do, they measure the light scattering of a helium neon laser beam into the anterior chamber. This technique is called laser flare photometry. You have to remember the name. Now, from practical point, some parts I want to share. So sometimes it is practically impossible to differentiate between pigments and cells. You have to remember that the pigments are a little smaller in size and these are brown in color, where the cells are yellowish white and little larger in size. And another important part, that whenever you are examining a photophobic patient, make sure you are using a very small width of the slit lamp beam. But otherwise, if you enlarge the beam, no, you won't be able to examine the patient because of the photophobia, and you may miss cells like +1 or 0.5 cells you may miss. So always make a very thin slit lamp beam when you are examining a patient, photophobic patient in slit lamp. Now, coming to the hypopion, you know always already that the deposition of the inflammatory circulating cells are actually called at the bottom of the AC is called hypopion, and the various causes are there: HLA-B27, ankylosing spondylitis, and Behçet disease. Now, Sahil, can you tell me what are the characteristics of hypopion in Behçet disease?
Sir, it is a mobile type of hypopion and pan uveitis picture, sir, and it has systemic features.
Yeah, fine. But I'm talking about, so Behçet disease has few characteristic. Number one is it is actually often it is called cold hypopion also, because there will be very relatively white eye, but there may be a hypopion. Unlike the HLA-B27, where there will be hyperacute, severe congestion and all, Behçet disease hypopion may actually present with minimal or nil congestion. That's why one terminology, often it is called cold hypopion. Second one, as you said, it is mobile hypopion. With the change of posture, the hypopion will change. Why it will change? Because there is very less fibrinous content in the hypopion, unlike HLA-B27. HLA-B27 hypopion won't change with posture because it has high fibrinous content. So this is how it is defined. And also you have to remember, sometimes it is called, sometimes it can be a trace hypopion. It is so minimal that you may miss the hypopion and only visible if you do a gonioscopy. So these are the very characteristics of the Behçet disease hypopion. And one thing you must know, that the mobile hypopion is not actually required for the diagnosis of Behçet's. Only 15% of the patients with Behçet disease will have hypopion. So does not mean that the patient is not having hypopion, he or she cannot have Behçet disease. Okay. Now I'll just ask any one of you to tell me, how will you differentiate a case of HLA-B27, a case of endogenous endophthalmitis, and Behçet disease? How will you take the history and how will you investigate? Any one of you?
Sir, B27 patient likely will be limited to anterior uveitic features, and sir, there can be history of lower back pain.
Very good.
Recurrence. While
So genital ulcers and oral ulcers in Behçet's disease.
Very good. And what else can we expect?
Sir, in endophthalmitis, there can be a septic foci source. Primary.
Very good, brilliant, very nicely done. So what investigation you will order in endophthalmitis, endogenous endophthalmitis?
Sir, vitreous tap.
Yeah, definitely vitreous tap. We also do sometimes when we can't locate the where is the source of sepsis is, then we also order urine culture, blood culture to that. And Behçet disease, what investigation you will do, Ayushi?
So HLA-B51, so HLA test.
HLA-B51, okay. Is it confirmatory? No, it does not rule out or rule in, but it definitely aids to the diagnosis. Any test, particular test, which is of very theoretical importance.
Pathology test.
Pathology test. Very good, very good. So you will already know so many things. So next, moving to the hyphema. First, let me tell you that most common three causes. One is trauma, virus, fuchs. Fuchs, why? Because sometimes after doing gonioscopy also, there will be some filiform arteries, arteries which can break and cause bleeding. In Fuchs uveitis, we call it, when this same thing happens in paracentesis, we call it Emsler's sign. Okay. Now in viral uveitis, because of the virulence of the organism, sometimes there will be heme in the anterior chamber. So hyphema is a common feature in viral uveitis. It can be seen in any uveitis, any severe uveitis, you can get a hyphema. Now coming to the corneal involvement. Our first entity is keratic precipitates. Now, what are the keratic various precipitates? By size, it can be large. We call it mutton fat. The medium, small. By size, we divide them into large, medium, small. By shape, we divide them mainly. Example is the stellate. With confocal, there are various linear extensions have been described. So you read about that. Now, in bicolor, you should know that there are called pigmented keratic precipitate, and there can be fresh keratic precipitate, which are white in color. Now, one thing you must understand, this is a very important part to understand, that the activity of a keratic precipitate is defined by its margin. Don't judge a keratic precipitates by color, because often we feel that if the keratic precipitates is pigmented, that
Partho, you are unmuted. We cannot hear you.
Unmuted. No, I am not. Hello? Can you hear me?
Yes, sir.
Yes, sir.
Yes, sir.
I don't know. Can you reshare your slides? Acha,
No,
you
they
can
can-
hear.
We
Everybody.
can hear you.
Problem is from my end. Okay, you can continue. Okay.
Okay. So, so what happened? Often I see the people say that it's a pigmented and old KP. No, it's not that. You have to remember that pigmented KP does not mean that it's an old KP. What happens? Pigmented KP means what? A lymphocyte has engulfed a iris pigment. So that's why it is looking pigmented. Now, if you, so the main idea to look at KP and differentiate whether it's fresh or new is the margin. Look carefully at the margin of the keratic precipitate. If the margin is sharp, crenated, then it is old. If it is not fuzzy margin, then it is actually fresh KP. This has been actually described by various authors with the help of confocal microscopy. So this is a very important point you should remember. The next important point here is the distribution of a KP. So the moment you examine a uveitic patient and you see the KPs are diffusely distributed all over the endothelium, you have to understand that there can be two possibilities. Number one, it can be Fuchs uveitis. Number two, it can be viral. So remember, in two uveitic conditions, there can be a diffuse distribution of the KP. One is Fuchs, another is viral uveitis. Next, how the KPs are normally distributed? It's distributed in Arl's triangle. Now, Arl's triangle, it's a base down triangle. All of you know. Now, who will tell me what is Turk line? Kavita, I didn't ask you. I don't know any. I know only three of you. Any other? Any postgraduates? Ayushi, what is Turk's line?
Sir, I'm not sure.
Sir,
Okay.
it's vertically deposited on cornea.
It's called the linear distributed. Very good. It's actually there in old Duke Elder, where they have described that the linear deposition of the KPs in a linear form. No, they call it Turk line. So next we'll go to. Okay, so the next corneal involvement is band-shaped keratopathy. So all of you know the deposition of the calcium hydroxyapatite in the Bowman's layer can be seen in conditions like chronic uveitis, juvenile idiopathic arthritis, and this condition typically begins at the periphery of the intrapalpable region and spares the central cornea. And now, if sometimes visual excess is involved, then it can cause severe diminution of vision. And slit lamp examination, this small clear dot-like areas, which will be observed, and this gives an appearance of Swiss cheese appearance. Now, why this this clear small dot-like areas we see? Can anyone tell me?
It's corneal nerve opening.
Very, very good. Who is that? Dr. Giriraj?
Yes, sir.
Yeah, very good, very good. So these are actually represent the location where corneal nerves penetrate the Bowman's layer. So that's why we see that as it is. Now, as a rule, if you have to understand the presence of BSK in a case of uveitis means poor control of the inflammation. So next time you see a patient with BSK, you have to understand that even there is a no cell, especially in JIA, even if there is no cells, there may be some flare until and unless you do a laser flare photometry. So this patient may have a poor control of inflammation. So next, corneal involvement is corneal scar. As you know, the viral etiology can have this corneal scar, and the peripheral ulcerative keratitis, that any corneal involvement in systemic vasculitis or any case of scleritis is a red flag sign. So it means that there is some presence of some systemic vasculitis with or autoimmune disorder. So you have to understand, if you examine a patient with scleritis and corneal involvement, you have to send the patient for rheumatologist to investigate aggressively, because this can be a sign of a lethal vascular disease. So if you send the patient timely, the timely intervention can not only save the eye, but also save the life of the patient. So this is very important to understand. So now coming to the synechia, all you know that the different type of synechias are there. You have to understand that sometimes you start the cycloplegic drop when the patient is developing synechia. So there will be dilatation of the part of the pupil. So that will give you a flower pattern of the pupil. We call it festoon shaped pupil. Whereas when there is an annular or ring synechia, we also call it seclusio pupillae, where you can see the crystalline lens. Now here, for example, there is annular and ring synechia, but you can't see the crystalline lens here. So we call it occlusio pupillae. So similarly, there can be peripheral anterior synechia. So one thing, synechia point of view, you have to know that the absence of synechia is a feature of Fuchs uveitis. So young unilateral patients in absence of synechia, that may actually lead you to a diagnosis of Fuchs uveitis. So keep that in your differential diagnosis. Now coming to the nodule, there can be Koppes nodule, Busacker's nodule, and Berlin's nodule. Now, what are these nodules? These nodules are basically aggregation of the epithelioid cells. The plasma membrane of these epithelioid cells are so sticky that they adhere to each other and form a large nodular cell connection, which we perceive as a Koppes nodules or Busacker's nodule. Now, who will tell me what is Berlin's nodule?
The sarcoidosis.
Sarcoidosis. What is it? Where you will find it?
Angles and trabecular
During gonioscopy.
Very good. Gonioscopy, you will find it. So the Berlin's nodule is a characteristic, or may be seen in, we won't call it characteristic. The Berlin's nodule can be seen in sarcoidosis. So now coming to the iris, you have to look for the pattern. So what are the different type of pattern you have to look for? One is whether there is any loss of fine pattern. So now you have to understand that in Indian, though we call it Fuchs heterochromic iridocyclitis, in patients with darker irises or in Indian patients, no, we don't see this heterochromia. It may be subtle. So how will you find out? You have to examine this iris near the colarete. You know that the anterior surface of the iris is divided by two parts, and this arbitrary line here is called colarete. So near the colarete, there will be a velvety appearance of this iris. So that's how actually the Fuchs uveitis is defined in darker iris. So it may not be the subtle iris color difference, but the loss of fine pattern. So always examine the patient under undilated condition. So in dilated condition, many a time you may miss the Fuchs uveitis. The next important is your atrophy. Now, why there is a atrophy in the viral uveitis? Because the viruses, the herpetic viruses especially, they are notorious to cause endarteritis. Now, this endarteritis will cause destruction of the iris tissue, and there may be segmental iris tissue atrophy. Now, when we talk about, as I said, the differential diagnosis, so you have to keep your list of differential diagnosis. So what are the other causes of iris atrophy? It can be viral infection. It can be anterior segment ischemia. It can be seen in leprosy also, syphilis also, and also any history of previous eye surgery, or most importantly, the previous attack of the angle closure glaucoma can actually cause severe iris atrophy. Now, coming to the intraocular pressure, one thing you have to remember, always you have to check the intraocular pressure. Never actually leave a patient without checking the intraocular pressure in your clinic. So now the decreased IOP, where you can see in ciliary body shutdown, especially seen in which condition? Anyone? Dr. Giriraj, are you there?
Yes, sir.
Yeah, ciliary shutdown can be seen in which condition?
Sorry, sir.
Okay,
Remember.
ciliary shutdown can be seen in HLA-B27 sometimes. So inflammation is so severe that it can actually lead to the ciliary shock also. Now, second is the chronic uveitis. So chronic uveitis, what will happen? The membrane will form over the ciliary body, over the pars plicator. So that will actually blunt your pars plicator region. So that will hamper the aqueous secretion, and that's why there will be decreased IOP. Okay, so the next, what are the mechanisms of raised IOP in uveitis? One is clogging of the trabecular meshwork with inflammatory cells. As you know, it's a sieve-like structure, though, so the inflammatory cells may go and actually clog the trabecular meshwork pores. So there will be a high rise in IOP. The second is there will be a trabeculitis. That means the trabecular meshwork is inflamed and the swollen trabecular meshwork will clog the pores, and so there will be resistant to the aqueous drainage. So there will be a high IOP. High IOP in this patient. The second is the peripheral anterior synechia and pupillary block from the posterior synechia. Both, as you know, this will obstruct the aqueous drainage, and there will be obstruction to the aqueous drainage. The fifth point is that there will be this corticosteroid, which will bring some conformational changes in the trabecular meshwork and will cause resistance to the outflow. So there will be a rise in IOP. We call them steroid responder or steroid response. And these are actually the patient actually can present with intraocular pressure. Now, sometimes you have to remember that the causes of hypertensive uveitis, so these are herpetic viruses, toxoplasmosis, sarcoidosis. These are normally present with high intraocular pressure, but any uveitis can actually present with high intraocular pressure. So it is mandatory to check IOP in all patients. Now, coming to the vitreous, always try to examine the vitreous with 78-90D and also with indirect ophthalmoscope. Now, cells in the anterior vitreous or retrodental space you have to see, and after pupillary dilatation, with the help of slit lamp, you can see the 3 mm of the anterior vitreous, and that gives you a very important insight that how severe is the inflammation, whether there is a presence of cells in that area, and sometimes you have to differentiate them from the pigments. Some vitreous hemorrhage, sometimes you may see the RBCs also, so you have to rule out various other conditions from the inflammatory cells. Now, when we talk about the sun classification, there is no standardized grading system for vitreous cells, unlike we have the cells and flare. So what they did, they actually took the National Eye Institute grading system for the to record it as a to take it as a grade. Only they have added the 0.5 where they defined it as a trace. Clear? So vitreous is grading. You have to we have taken it from the National Eye Institute. Now, severe vitreitis and yellowish lesion. What are your differential diagnoses? Now, you are seeing a patient with severe vitreitis, yellowish lesion. It can be mainly 4 of this picture. The number 1, you can see this kind of full vitreous, hazy vitreous, but you can see inferiorly some exudates like this. Or sometimes, what is this then? Then it is intermediate uveitis. Sometimes you can see severe vitreitis, but you can see the periphery, some yellowish white patches, which is confluent and almost involving the 360 degree. Beware, this is actually can be a case of acute retinal necrosis. The third point where you can see a focal cause of retinitis, where you can see that there is a headlight light appearance, then it can be a toxoplasmosis. The fourth, you can see severe endophthalmitis like picture or severe vitreitis, but there is a tractional band. So it can be seen in toxocariasis, where the periphery and the optic nerve is often involved with a tractional band. Now, here you have to understand the vitreitis you see is mainly the products of the inflammation. Now, this product of inflammation can be tissue cells, various macrophages, and fibrinous clump, which is actually clogging over that. For example, in toxoplasmosis and in acute retinal necrosis, there is continuous destructive procedure is going on. The sloughing of the retina and entire thing is coming and being deposited in the vitreous, and it's becoming turbid. So in that scenario, you have to understand that with the antimicrobial therapy, you have to give oral steroids so that it can be cleared off. Now, when we talk about vitreitis and yellowish lesion, you have to remember two important points. One is, don't forget the lymphoma, especially if the patient is elderly. You have to always keep in mind that there can be a possibility of lymphoma. And also, you have to keep a check that whether you are not missing the endogenous endophthalmitis. Now, yellowish white lesions in fundus, it can be any cause like choroiditis, retinitis, retinochoroiditis, chorioretinitis, tubercle, anything it can be. So we'll go phase by phase. So first important is for the postgraduates, you see a yellowish white lesion, you have to differentiate between retinitis and choroiditis. Now, retinitis, theoretically, it appears as a yellowish patch, and choroiditis is, a whitish patch, and choroiditis is yellowish patch. And retinitis have ill-defined margin, and in choroiditis will have well-defined margin. But in a dark room, when you are performing fundus examination, it is not that easy. That time it's not that easy to find out that whether it has a margin, what kind of margin, what kind of color. So always remember in that case that always trace the retinal vessel. The retinitis, as you see here, retinitis will be superficial. As you can see here, it has obscured that retinal vessel here because it is located here. And in choroiditis, as you can see the retinal vessel clearly. So similarly here, you see this in this diagram, the choroiditis is located here, so you can actually see the retinal vessel clearly. So in case of doubt, trace the retinal vessels. It will tell you whether it's a choroiditis or retinitis. Now, the classification of posterior uveitis is very important because it gives you various terminology that choroiditis, chorioretinitis, retinochoroiditis, retinitis, neuroretinitis. You have to understand these are all umbrella terms. All these terms are kept under an umbrella of posterior uveitis. This can have various causes, or single cause can have various presentation. For example, syphilis, it can have presentation with chorioretinitis, it can present with retinitis, it can present with neuroretinitis, or a cause of retinitis can have several causes, like it can occur due to syphilis, it can due to herpes simplex viruses, it can have due to chikungunya viruses. So it has various causes, and similarly various presentation by single etiology. So we don't treat a particular entity. Like you cannot treat a case of retinitis. You treat the etiology here, not the terminology. Correct? So in clinic, you can't treat a case of choroiditis, you can't treat a retinitis, you treat the cause of the particular clinical phenotype. Now, always remember that retinitis is almost always infective except for two conditions. One is Behçet disease, another is intraocular lymphoma. Now, in Behçet disease, the retinal involvement is mainly through the small nodule you will see. These are called retinal infiltrates. In Behçet disease, intraocular lymphoma, you will see subarpic cream-colored patches, which can actually sometimes give mimic the retinitis. So, retinitis is almost always infective only for Behçet disease and for intraocular lymphoma. Now, how to decode a case of retinitis? Look for some clinical pattern where first check the number, whether it's a focal or it is multifocal. Next, check the location where the retinitis is, what is the clinical phenotype? Is there any spatial predilection? Is it in the periphery or it is around the vessel? What is the shape of that? whether it's having some particular clinical characteristic. For example, if you see the focal means it is most of the time it is protozoal. It can be toxoplasmosis, it can be cysticercosis, but mainly focal single lesions are associated with protozoal lesions. The multifocal is, on other hand, it is it can be viral retinitis, it can be syphilis, it can be due to DUSN, and it can be due to candida. Clear? Any doubt, any question you have?
Keep on adding your questions. If you have any doubts, simple or complicated, in the chat box, and we'll answer that.
Okay. Vishal, I'll take just 1 minute break. I'll have some water.
Sure, sure. Take your time.
So, look at the lesions, that whether it's a focal or multifocal. So next we'll go to the location of the retinitis lesion. So now I'm audible, right?
Right.
Okay, so now location of the retinitis, you have to see that whether the lesions, if you see a retinitis lesion in the periphery with the confluent retinitis patches, and which is coalescing almost 360 degree, and if you look at the border, these are we called actually scalloped edges, and if you see, you will see some occlusive vasculitis, then it is the case of acute retinal necrosis, and it's an ophthalmic emergency. You have to treat them aggressively with antiviral treatment. Now, sometimes you can see retinitis in the posterior pole. Now, unlike acute retinal necrosis, the progressive outer retinal necrosis starts from the posterior pole, and it has an extremely rapid progression towards the total retinal necrosis, and it is very, very difficult to manage. So this is actually mainly seen in profound immunosuppressive individual, mainly the HIV patients. Luckily, with the advent of the anti-retroviral drugs and all, nowadays we are not seeing this kind of cases. And another characteristic of PORN cases are there will be minimal or very almost absent inflammation in aqueous humor and vitreous. Only you will see the severe retinitis affecting the posterior pole. Now, another can be posterior post-fever retinitis. Now, what are the causes of post-fever retinitis? It can be viral. Any virus can cause post-fever retinitis, and it can be bacterial also, like can be seen after typhoid fever or rickettsia infection. So you have to rule out them with the proper history and investigation also. So now look at the clinical pattern. Some retinitis you will see, these are vasocentric in nature. So any vasocentric retinitis with hemorrhages, highly suggestive of cytomegalovirus retinitis. So you rule out CMV retinitis when you see vasocentric patches. Now, sometimes you will see retinitis with ground glass appearance. What is ground glass appearance? That means you can see what is happening beneath that. For example, if you see here, you can see that the occluded retinal vessels, and you can there see some sub-RP, small creamy white retinal precipitates. So retinal involvement in syphilitic panuveitis has this kind of opacified appearance. Now, this is very distinct from typical white necrotizing retinitis seen in herpetic retinitis. So next time you see a case with ground glass appearance, you remember that this is not herpetic retinitis. This is syphilitic retinitis. Why? Because it is presenting with a transparent ground glass retinitis look, and this kind of, if you treat these patients with penicillin, this will heal actually with minimal disruption of the retinal pigment epithelium. And after healing, hardly you will be able to recognize that there was any kind of inflammation other than some coarse stippled hyperpigmentation. So it will healed very nicely in compared to the herpetic retinitis. A very rare entity is acute syphilitic posterior placoid chorioretinitis, so which will have a yellowish one or more placoid kind of lesion, typically at or near the macula, and which will have the faded actually center. Now, syphilis, if you remember the William Osler saying that he who knows syphilis knows the medicine. The same is applicable to in uveitis. He who knows ocular syphilis knows uveitis. It is a king of masquerader, and high index of suspicion is required. Always place syphilis in the differential diagnosis. Whatever uveitis you are seeing, be it a episcleritis, be it a scleritis, be it anterior uveitis, always rule out syphilis by serology. So it should, next time you see a case of uveitis, the syphilis serology should be included in your workup. Clear? So next, sometimes we have, like we see in Instagram and various, no, twinning. So sometimes you will have like retinochoroiditis, and then there can be chorioretinitis. So what will happen, because these are adjacent, the spread of the retinitis to the contagious choroid can happen. We call it retinochoroiditis. Now, what example? The example is toxoplasmosis. Now, similarly, the retina may be inflamed secondarily to the adjacent choroid involvement. We call it chorioretinitis. Classic example is your syphilis. Clear? So now coming to the choroiditis, you have to understand that there is some confusion between the terminology. You have to remember there is a choroiditis called autoimmune variety, which is serpiginous in pattern or map-like, geographical map-like. We call it serpiginous choroiditis. Similarly, similar pattern choroiditis can happen due to infectious etiology, mainly due to tuberculosis. We call it serpiginous-like choroiditis. So, serpiginous choroiditis means classical autoimmune. Serpiginous-like choroiditis means infectious etiology. Clear? Now, serpiginous-like choroiditis is a distinct form. It is often characterized by this kind of form also. This is called multifocal serpiginate choroiditis also. So in a country like India, if you see a serpiginous choroiditis, your primary duty is to rule out tuberculosis. And after that, if all other infectious etiology you have excluded, then you can treat as an autoimmune. Whereas in Western country, they mainly treat it as an autoimmune condition and with the aggressive immunosuppression. Whereas in developing country, serpiginous choroiditis or this kind of multiple serpiginate-like or multiple choroiditis, we need to rule out tuberculous etiology primarily. Now, there are various types of choroidal involvement. So sometimes what happens, we use it, for example, this kind of tubercle, often they use as a multifocal choroiditis also, because the term choroidal tubercle and choroiditis, sometimes they overlap. So you have to understand that the choroidal are the small, tiny patches scattered all over the fundus, and there can be some solitary nodules. Sometimes we call it tuberculoma, and then there are some entity where there will be pathogens multiplying, leading to the caseous necrosis and various liquefaction of the retinal tissue. And we use various terminology. We call it sometimes chorioretinal abscess, we call it choroidal abscess and subretinal abscess. So there is no clear-cut guideline for naming of this clinical entity, and interchangingly the many various authors use various terms. Now, when we talk about subretinal abscess, many of us, we feel that the most common cause is Mycobacterium tuberculosis. No, it is not the fact. It is the most probably the second, because if you read this article, the most common cause of subretinal abscess is nocardia. According to this article, which have done a systemic review, nocardia, the second cause is the Mycobacterium, and then comes the Klebsiella. So you have to rule out, you have to keep that mind in TB, but does not mean that all subretinal abscess is due to tuberculosis. Now, another important, when the retinitis involves the optic nerve, we call it neuroretinitis. Now, classical triad of neuroretinitis comprises of number 1, disc edema, number 2, macular stir, number 3, the unilateral vision loss. So unilateral, I have kept it in bold letter because it is the most important point. Why? If it is, for example, similar kind of condition like this photograph, similar kind of condition you are seeing in both eyes, that means the neuroretinitis in bilateral involvement, you have to understand that it can be due to some other systemic cause. So it is mandatory to rule out some systemic disease like malignant hypertension, diabetes mellitus, elevated intracranial pressure in such conditions. So remember, Neuroretinitis is almost always unilateral and comprises a triad of disc edema, macular star, and unilateral vision loss. Now, what are the causes of neuroretinitis? It can be seen in toxoplasmosis, toxocariasis, cysticercosis, herpetic retinitis, syphilis, sarcoidosis. And you have to also, when we are talking about the neuroretinitis, you have to understand that there are certain conditions where optic nerve is also involved. Now, Ayushi, Sahil, Kavita, can you tell me some common uveitic condition where optic nerve is involved?
Sir, sarcoidosis.
Very good. Go on. Go on. Huh?
Sir, syphilis.
What about Ayushi, Kavita? Okay, so see, right, sarcoidosis. So second, it can be seen in posterior scleritis also. One important point you must note, tell that Vogt-Koyanagi-Harada disease, sympathetic ophthalmia, Behçet disease. So in these conditions, actually commonly optic nerve is involved. Now coming to the retinal vasculitis. So you have to know that there are certain conditions where arteries are involved, like acute retinal necrosis, the systemic lupus erythematosus, and Behçet disease. Whereas in veins are involved mainly in the sarcoidosis and frosted branch angiitis. Now you have to know about certain clinical phenotypes of the retinal vasculitis. The number one is Chilaris periarteritis. The number two is frosted branch angiitis. Number three is candleworks dripping. And I want to highlight also fund-like pattern in angiography, fundus fluorescent angiography. Now, Chilaris arteritis, it is the deposits over the arterial wall or the migration of the exudates. As you can see here, it is a case of toxoplasmosis, and you can see here the vessels are actually, you can see that there are plaque-like material deposited over the vessel. So these are called Chilaris arteritis. Now, Chilaris arteritis most commonly seen in toxoplasmosis, but it can be seen in Mycobacterium tuberculosis, syphilis, rickettsia, or any viral infection. Now, the frosted branch angiitis, it looks like a frosted branch. Can any one of you tell me how to differentiate between a Chilaris periarteritis and frosted branch angiitis? How will you differentiate?
It's a perivascular seeding in frosted branch.
Kavita, very good. But how will you confirm that it is perivascular shedding? It is not the inflammation of the blood vessel.
FFA.
Very good. So brilliant answer. So if you do a fundus fluorescent angiography, the Chilaris periarteritis, because the plaques are deposited over the vessel wall, it won't leak any fluorescent dye. Whereas in frosted branch angiitis, it will leak the dye because the vessel is inflamed. Now, candleworks dripping, where it is found, it is seen in sarcoidosis. Now, fund-like pattern in angiography, where it is seen? It is seen in Behçet disease. Very good. So this is how we actually identify the various clinical phenotype. One more clinical phenotype is exudative retinal detachment. Now this exudative retinal detachment, there are several causes of exudative detachment. If you see here, there are some medical conditions which can actually present with exudative detachment, and you need to actually differentiate them from the uveitic entity. Namely, the most important is central serous chorioretinopathy, Coats disease, uveal effusion syndrome, nanophthalmus. Whereas in inflammatory, the most common cause will be VKH, any kind of chorioretinitis. It can be sympathetic ophthalmia. It can be posterior scleritis. Also, you have to remember that any kind of choroidal metastasis or hemangioma can present with exudative RD. Similarly, there are certain systemic causes which can actually present with exudative RD. So exudative RD basically a clinical science, and you have to rule out various other causes to reach your diagnosis. Now, the most common, perhaps the most important cause for your exam purpose also that presents with exudative RD is Vogt-Koyanagi-Harada syndrome. Now, it will present with exudative RD with pan-uveitis and with systemic involvement. Can any one of you tell me what kind of systemic involvement a patient of Vogt-Koyanagi-Harada syndrome will have?
The hearing loss,
Neurological and
lesions.
alopecia.
Very good. Very good. You people are so good. No, you're answering all questions. Very happy. So it will have that melanocyte, the T cell activation will be there against the melanocytes, and which is located in various cartilages and meninges. So there will be, the patient will have headache, the patient will have tinnitus, the patient will have various systemic symptoms with the skin vitelliginous patches. So it will manifest with various systemic manifestation. Now, this is very important that to understand the fundus fluorescent angiography, the ultrasound. Earlier, when we were doing fellowship, we used to read that the ultrasound is very characteristic of leakage because it showed choroidal thickening. But now it has actually choroidal thickening can be in various conditions. The most important perhaps that the configuration of this, if you see this the intralobular arrangement, no, in Vogt-Koyanagi-Harada disease. So this intralobular configuration, which is actually caused by the inflammation-induced fibrous septa, and this is what reflects in the fundus fluorescent angiography. If you do a fundus fluorescent angiography, you can see early stages, it will have the pinpoint leak, and this leak will gradually enlarge in this septa, in these pockets, and we'll see a characteristic finding. It is called the placoid pulling of the dye in the late phases. Now, because the treatment of this cause is with the high dose of steroid, often with intravenous methylprednisolone, you have to do a fundus fluorescent angiography to differentiate it from CSR. Now, how to differentiate from CSR? The CSR will have the leak, which will start with pinhead leak, but as the angiography will progress, it will show the increase in size and intensity of this clinical lesion, this pinhead leaks. Whereas in Vogt-Koyanagi-Harada disease, it will show the placoid pulling of these dyes. Clear? Now we have come to the last part of our presentation only. So the pan-uveitis. For exam purpose, always remember this TVS. So there are these causes. You can actually, the T stands for tuberculosis and toxoplasmosis. The Vogt-Koyanagi-Harada disease and viral disease like acute retinal necrosis can have a presentation like pan-uveitis. And also with S stands for sarcoidosis, syphilis, Behçet syndrome, sympathetic ophthalmia. So this is how you can remember. Now you have to remember that certain conditions like the toxoplasmosis, acute retinal necrosis, this can have both posterior uveitis like picture and pan-uveitis like picture also. So these actually fit into both the causes. So you can use them enumerating the causes of both pan-uveitis and posterior uveitis. But classically, Vogt-Koyanagi-Harada disease, sympathetic ophthalmia, Behçet disease, and these are primarily the entity which will present with pan-uveitis. Now we have come to the last end because it is not possible to go into that. So I'll just use 3 slides for teaching you the investigations in uveitis. The first one is that how to look for the systemic rheumatic disease. So I'll give you 3 clues. The first one is you have to remember that no single test is diagnostic. That means these are non-specific. For example, if you are suspecting rheumatoid arthritis, you have done the rheumatoid factor, it is negative. That does not mean that patient is not having rheumatoid arthritis. So similarly, if you are syphilis, ANA comes negative, though it is very sensitive, does not mean that it has completely ruled out the SLE. So no biomarker is diagnostic. Next, whenever you are suspecting systemic rheumatic disease, you have to understand your limitation. Always refer this patient to a rheumatologist. Write a letter that what you are suspecting and what you want him to rule out. Number 3, a biomarker can be positive in later course of the disease. Today, I have seen a case of scleritis. I remember I have investigated this child today in outpatient department. I have seen this patient actually 2 years back. I have investigated all investigations. Everything was normal with a rheumatoid factor negative. When this time in this visit, when we have done the test, today the patient has come and the rheumatoid factor was positive. So a biomarker can be positive at later course of the disease. So you may have to repeat it also after a certain point of time. Now coming to the laboratory investigation in granulomatous uveitis, this is important because various theoretical question comes from this area, and many of may have a dilemma while deciding this treatment in in your clinic also. So that we basically use actually 6 parameters. So how we use them? First is the Montu test. Even if it is a positive or negative, it aids to the diagnosis. How? Montu test positive, there is a latent possibility of latent tuberculosis. Now, if the Montu test is negative, now energy to the tubercular protein is a characteristic of which disease? Anyone?
Sarcoidosis.
Sarcoidosis. So a negative Montu test also valuable in a case of granulomatous uveitis. It may point out toward a sarcoidosis also. So this is positive or negative Montu test is important. HRCT, nowadays we have stopped doing chest X-ray because HRCT is superior both in TB and sarcoidosis because they can pick up the lymphadenopathy more accurately than a chest X-ray. Now, then we have the interferon gamma release assay. So both this serological test also gives you idea whether the patient is having latent tuberculosis or not. We are not going into the detailed discussion of TB. One thing you have to remember, positive or negative Montu test or interferon gamma release assay does not rule out or rule in tuberculosis. Okay, it is mainly the clinical phenotype which actually defines a ocular tuberculosis nowadays. Okay, we use them as a supportive treatment. Now, serum angiotensin converting enzyme and serum lysozyme, these are the same, measure the same parameters. What parameters? They measure the granuloma load due to sarcoidosis. Now, if it is ocular sarcoidosis, very limited, that the serological test may not be positive because it will measure the total load of the sarcoid granuloma in our body. So if it is limited only to the eye or only to a particular organ, it may give a false result also. Sometimes if the patient is taking some other drug or oral steroid or serum angiotensin angiotensin inhibitor, so it can give you a false result. So the classical or definitive test for sarcoidosis is the bronchial biopsy. Now, coming to the liver function test, how it aids to the in our clinic, because it is raised in sarcoidosis. It is also advisable to do this test because if you are planning the patient for methotrexate or any immunosuppressive therapy, and also if you are planning for anti-tubercular therapy, then the liver function test is very helpful. So PCR for Mycobacterium or any tuberculosis has limited option. Sometimes the results are not very accurate if the sample is not corrected properly. And also it has various other issues like cost factor, availability, and case selection. Now, serological test, because as a postgraduate, I want to give the most valuable tips on laboratory investigation. Don't use serological test alone to diagnose the infection. Only exception is syphilis and HIV. Rather, as I mentioned earlier, you should indicate everything. Every uveitic entity should have the inclusion of these two serology. Don't use serology such as torch titer, anti-toxoplasma, anti-toxocara, quantiferin, and diagnose infectious uveitis only based on them. For example, the herpetic virus titer. These are actually ubiquitous organisms, so it can be positive in any individual. If you see these two studies, the 92% of the human actually shared HSV in their tear, and in autopsy, 93% of the human autopsy showed the HSV DNA in their trigeminal ganglia. Because these herpetic viruses are ubiquitous, they are omnipresent in a human being, so they can give actually false positive results. So don't treat a patient only on the basis of positive torch titer. So I'll just conclude that the knowledge is not power, it is only the potential. So applying this knowledge is a power. So you have to understand why and when you have to apply this knowledge, and that's called wisdom. Thank you for your patience hearing. I'd be happy to take any question. You have anything?
Father, there's a question. What is DUSN? Can you?
What is? I'll just. It's a parasitic uveitis, no diffuse uveitic. The parasite will move, so you will see the track there and will diagnosis there. So I'll go to the quiz directly, Vishal, or
Just, yeah, you go to the quiz. Just you'll all the participants will get around 10 seconds to answer the quiz. You just type your answer in the chat box, and the first correct answer will get a grand prize, and that grand prize will be delivered to his or her working place or residence. You can start with the first grand quiz question.
no prize for the quiz master?
I'll give you that in person when you meet me.
Okay, chalo. So let's go to the first quiz question. A patient presented with history of blurring of vision, ocular pain, and redness of right eye for 1 week. Examination findings shows cells 3+, clear 3+, severe vitreitis, vitreous haze grade 3, and how will you level this inflammation according to such classification? Anterior uveitis, pan uveitis, intermediate uveitis, none of the above.
Okay, time is up.
Up. Okay. I'll show the answer.
Yeah.
So the correct answer is none of the above. So why? The Sun classification says inflammation in the anterior chamber and vitreous when it is more vitreitis than the iridocyclitis and more anterior chamber inflammation than in intermediate uveitis should be referred as anterior and intermediate uveitis and not as pan uveitis. Correct? I think discussed this.
Aditya Patel was the first one to answer that. Most have answered B or C.
Congratulations, Aditya. So we'll go to the second.
We'll proceed to the second question.
So second question is a spot.
One word question, one word answer?
Yeah, one word answer. So you have to tell me that answer. So identify a ophthalmic condition in a 6-year-old child, known patient of juvenile idiopathic arthritis, recurrent attack of anterior uveitis, and your picture is here. These cheeses are actually riddled with the holes known as eyes. Very easy question. Because of this fermentation, no, they cause the fermentation, so carbon dioxide bubble emerges out from this cheese. So that's why we see this kind of air bubble coming out, and that's why this particular appearance here. You have to tell me the answer.
Time is up.
Time is up. So I'll show the answer. Vishal, can I show the answer?
Yeah. We're waiting for the answer.
So answer is band-shaped keratopathy. The Swiss cheese appearance can be seen.
So there are answers of band-shaped keratopathy and Swiss cheese. What would you prefer? Swiss cheese as a specific answer or a BSK?
You have to tell me the diagnosis. So you have to tell me because Swiss cheese, I showed the photograph only. So we need the answer, band-shaped keratopathy.
Excellent. So let's see. Everybody has answered. You put a simple question, man.
Yeah.
Okay. Rishabh Gupta. Congratulations, Rishabh.
Congratulations. So that means
your prize, fancy grand prize on behalf of Rajasthan Ophthalmological Society will be delivered to you. So you can stop sharing now. Okay.
Yeah.
So, congratulations and thank you to Dr. Partho for the wonderful class. We all know that uveitis is a vast topic and it cannot be covered in one single class. But still, it was a very comprehensive session. And any doubts, any remaining pending question, you can approach the Kaksha WhatsApp group and you can forward your queries to his email address, and we'll be more than happy to answer them in the coming days and weeks. And thank you to the speaker, all residents and the teachers who have joined us today, and keep giving us your valuable feedback to improve the Kaksha experience in the future. We'll be again back next week with a new topic, pertinent to the resident training, their actual OPD experience and their practical real life scenarios. We are covering most important and most common topics, which are just not asked in the question, but which will help them in the OPD and daily diagnosis and in their practice. So it's also very important, these classes for the general practitioners. And the second thing is that all these classes are uploaded and they are live on YouTube. Dr. Rakesh Porwal is here, head of the department, Ajmer Medical College. Sir, good evening. Any comments before we close?
No, I would like to congratulate you, sir. I would like to thank you, and on all the behalf of all the residents, I am really pleased that what ROS has to do it has started, and we are really learning. Myself as a teacher, I am also learning many things, and I keep on propagating. All the residents are there together in the class, and we all attend together in a single motion, sir. Thank you, sir.
Great initiative, sir. You are always on the forefront of learning and you are leading by example. And we need more teachers like you. Thank you, Partho. Good night from ROS. Good night from team. Take care and we'll be meeting next week. Thank you so much.
Thank you.